Good morning, everybody. I want to welcome you to our Stanford Patient Pituitary Education Day. I'm Laurence Katznelson. I'm an endocrinologist. I'm the medical director of our Pituitary Center at Stanford. Our goal today is to kind of introduce you or educate you to some of the nuances of management of pituitary diseases. Many of you have these problems. Many of you are family members of people who have issues regarding the pituitary system, whether it is you've had surgery or will have surgery, have various disorders that we manage. And the difficulty we know is that it's hard to obtain information on this. When I or my colleagues sit down with you and try to explain a lot of this, there's a lot of information. And unfortunately, in the internet, it's difficult to acquire this information. Pituitary tumors do have sites where you can get this information, but it's hard to really get this. And we thought this would be a great opportunity to introduce you to some of the more details of pituitary diseases, whether you have low function, high function, need surgery, whatnot. Also, this is an opportunity for you to meet each other. This morning's sessions are going to be based upon just us giving lectures and having some time for questions. This afternoon, we're going to have breakout sessions, as you know, where we're going to have separate groups that may be more pertinent to your needs. This is an opportunity not only to have more focus on information that's more applicable to you, depending on what kind of pituitary disorder you have, but also gives you a chance to hear from each other. And there's a lot of learning in that way of experiencing what other people have experienced. Using medications, acquiring medications, what the surgical experience was like. This is a great opportunity for you to meet each other and discuss this. There are not that many opportunities to do such in the world of pituitary disease, and this is one opportunity to do such. It's a unique opportunity. So I would like to introduce a couple more of my colleagues. Dr. Robert Dodd is sitting right here. He's a neurosurgeon. Many of you may know him. He's wearing a mask when you meet him, so you may not recognize him now. And he will be speaking in a few moments as well. And the surgical director of the program is Juan Fernandez-Miranda. Now, Juan came to us, to Stanford, about a year ago, I believe, from the University of Pittsburgh, and just an outstanding addition and a very highly experienced surgeon as well. So I'm going to pass the baton. As I stand up for a minute, Juan? Dr. Fernandez-Miranda. To introduce. Juan. Today you can call him Juan.
Thanks, Larry. So good morning and welcome everybody. It's great to have you here. As Larry said, I've been here at Stanford for about 9 months now. They recruited me to run with him and with my colleagues, the Pituitary Center, and it's been an enormous pleasure to join this team group of colleagues. I've been so satisfied. The most important thing what we do is you. It's about your patients, about you being satisfied, happy with the outcome, and all our efforts are destined to make your quality of life better. And I think we often achieve that, but not always. So this is also an opportunity for us, for me, to learn, how can we do things better? What are we missing? What should we do different? And that's why we want this to be an interaction between you and us, so we can learn from you how can we become better. So please feel free to ask any questions. This is going to be hopefully interactive. And also, please excuse maybe Dr. Dodd and myself. We are the surgeons in the room, and we like to show surgery. And if any of you are sensitive to these things, please forgive us. But we're going to show you some of the technicalities of surgery in a little bit. But Dr. Katznelson will show you some of the medical aspects of pituitary disease that I think are critical and very important. So welcome, and I hope you have a good day. Thank you.
Thank you. I think what Juan was trying to say is my slides have no blood, and his may have some. So I think that was the point you were making. Yeah. Okay. So to emphasize again, this morning is meant to fill in some details, kind of in a lecture-style format of pituitary disorders, approach to pituitary disease. You'll be meeting our ENT colleague in a few minutes who will also speak about how the ear, nose, and throat physicians approach these issues in terms of surgery. This is meant to be interactive, as you've heard. There will be many times for questions as the day goes. And again, during the breakout sessions, they're fully going to be discussion formatted, so there'll be plenty of time. What I'm going to do over the next minutes is give a general orientation to pituitary disease with an emphasis on the types of tumors. Do you hear me in the back? Is this working? With an emphasis on the types of pituitary tumors and other disorders that we see here. You're going to be hearing after I speak about the surgical approach. I'll be spending time on the medical approach to these. And again, this is meant just to be an introduction, and we will have time during the course of the day to spend more time on details. So this is just a plain old diagram of the head and where the pituitary gland sits. So this is obviously the nose and the back of the head. So this person is facing towards me right now, the side view of the head. And behind the nose, there's a little cavity, a bony cavity at the base of the skull called the stella turcica. The stella turcica is just a bony cavity that the pituitary gland sits in. And as you're going to be hearing in much detail, the surgery goes through the nose up to the floor of this bone, of this cavity, and that's where the hole is made to remove the tumor. The pituitary gland sits right in this bony cavity under the brain and the base of the skull. So all of these diseases really are not in the brain, but under the brain. That's an important note. So that's just a basic diagram. And here's an MRI scan, and you're going to be seeing a number of MRI scans over the course of the day. I'm not sure if by lighting this is difficult to see in the back, so I'm just going to describe what you're seeing. So right in here, this is a view of the front of the person's head. So the eyes are in front of the screen right here. And the pituitary gland is right here connected by, do you see this line, this vertical line right here? The vertical line is called the stalk of the pituitary, and it's essentially blood vessels and nerves that come from the base of the brain, called the hypothalamus, into the pituitary gland and feed it and bring factors and nutrients for the pituitary gland to function. This area right above is the eye nerves. That's the optic chiasm. So the eye nerves sit right above the pituitary gland. And as you'll see, when there's a pituitary growth and it moves upwards, it can push on these eye nerves. There's brain to the side, left and right, and above. So it's sitting underneath the brain. Now this is an example, not an unusual example, of a pituitary tumor. And what I'd like to point out is here, this is the brain. And here is the mass right here of the pituitary tumor. It has moved upwards right next to the optic nerves, the eye nerves. It was called the optic chiasm. And when the tumor pushes on these eye nerves, it can result in some loss of visual function. Usually what that means here is that people lose vision on the outside. So it's not the inside of vision that gets impacted, but it's the outer vision initially, called the temporal, the outside part of the vision. This is a view of a pituitary tumor from the side. Though the pituitary tumor here is all in white. And what you're seeing here, this black area below, that's an air pocket. That is what's called the sphenoid sinus. It's a sinus behind the nose that's right here. So the surgery, trans, which means across, sphenoidal. That's the name of the sinus. It goes right through here to get to the pituitary tumor. And you'll be hearing a lot more about this. So this tumor is fairly large and it's moved upwards, pushing on those eye nerves. So the person who has this tumor likely has lost some vision. Again, mostly off to the sides, the side view vision. But this would be a person who would be very concerned about visual loss in the setting of a pituitary tumor. This is an MRI that has an arrow in it. That's always helpful for us to see what's happening. This is painted on, of course. So this is pointing to a small growth in the pituitary gland, what's called a small adenoma or a microadenoma. When we look at these tumors, and you may hear us speaking, we we distinguish two types of tumors by size. One is called a microadenoma. That means it's small, less than 1 centimeter, 10 millimeters. And the other ones are macroadenomas, bigger than that size, bigger than a centimeter. The one I showed you before was more of the macro size. That was about 2 or 3 centimeters. So this is a smaller growth. This is a very common tumor size in people that have Cushing's disease or have prolactinomas. Very common. Usually people who have growth hormone tumors like acromegaly are much larger than this. And here you see that the optic nerves, the optic chiasm, is sitting there. It's clear. There's no tumor pushing upon it. So this person would not be at risk for visual field loss. So when we think about the pituitary tumors, and I'll be discussing other tumors as well as we go, there are 4 main types of the pituitary tumors. There is the acromegaly. Those of you who have heard of patients or have had acromegaly, these are pituitary tumors that come from the cells of the pituitary gland that make growth hormone. We're going to be spending some time on growth hormone today, but essentially these tumors come from individual cells in the pituitary gland that just divide, and become a growth, a pituitary growth. And depending upon which cell is the one that started to divide, that's the type of tumor we'll have. So if the tumor comes from the growth hormone cells, that is called acromegaly. That means people get overgrowth, and we'll discuss that. If the tumors come from the cells that make prolactin, that is called a prolactinoma. These are tumors where it makes too much prolactin, and we'll discuss those as well. The LH and FSH, these are the 2 hormones that are critical for reproduction and important for women having fertility and menstrual cycles, and a male to have testosterone function, sperm function. If those cells divide, people don't look abnormal. They look normal, but those of you who've had this kind, it's called a non-functioning tumor, where people don't look like they have overgrowth, the acromegaly, don't look like they have too much steroids, the Cushings, and yet they have this growth. It's probably the most common cause we see, and these are called the non-functioning variety, and these are the ones that the only therapy we really have is surgery. And Cushing's disease are people that make too much steroids because they make a lot of the hormone ACTH. And we'll discuss this, but the important point is that the cell type that divides will be the one that will cause the features of that person's disease. If they make ACTH, prolactin, or growth hormone, there'll be functional tumors causing certain characteristics. Okay. So I'm going to speak about prolactin tumors, and we talked that this is one of the types of diseases we see. It's a very common disorder, the prolactin tumors, and so prolactin is a hormone. For any woman in the audience who's been pregnant, this is the hormone that allows the breast to develop for nursing. This is the nursing hormone. Lactin is lactation, and so when during pregnancy, prolactin levels rise, and that allows the breast to develop to nurse. And this nursing is stimulated with a suckling stimulus at the end of obviously after delivery. Now, in abnormal situations, when the pituitary gland makes too much of this prolactinoma type tumor, the body's tricked into thinking it's pregnant, essentially. So in a woman, what would generally happen is a woman would present with nipple discharge and losing periods. That's how this presents in women. In men, it will present a little differently. Most men don't have periods, and what they have is sexual function, and the erectile function will diminish. The men will lose their libido. So that's how it presents in men. So it's a similar scenario. Again, the body's tricked into thinking it's been pregnant. This can present in other ways. It can present with infertility. So it's not an uncommon cause of infertility for women who are having irregular menstrual cycles. They present because they've had a hard time conceiving. And lo and behold, the prolactin level when measured is high. And that makes us think about the presence of a pituitary tumor. The other thing we worry about in these types of tumors is that these tumors, particularly in men, can grow large. And when they grow large, they can push upon local structures, and that can include blood vessels. It can include the eye nerves I showed you in the picture a moment ago. And if that happens, we need to make sure that our management not only involves lowering the prolactin, but also taking care of the local structures to make sure we can regain person's vision and prevent further visual loss. So the prolactin tumors present not only with these changes in the biochemistry and in medical issues, particularly with regard to reproductive function, menstrual cycles, fertility, and in men, sexual function, but also the fact that these tumors can be pressing upon these local brain structures. And our therapy needs to be tailored to address each of these. So now prolactin can rise in a number of normal situations. And that can, in fact, sleep. Prolactin generally goes up when we're in deep wave sleep. We don't generally have people measure it at that time, but I've done studies on this, as in many others, where we bring people to hospital, we measure prolactin at night, and it's often highish during the deep wave sleep. After exercise, after food, after stress, prolactin levels can rise. So, for example, if someone has a prolactin level measured and it's a little high, we always ask, did you just have a meal? Were you just running up 5 flights of stairs to get to have the test done? And if that's the case, we ask people to repeat the value, kind of a non-stress fasting state, and often the level will come back down to normal. It can also rise, of course it rises during pregnancy, so if a woman has a prolactin level measured and she's in the middle or near the last term of pregnancy, that is not a time to measure because it's going to be high, because that's normal. The woman's expecting this level to be high to prepare for nursing. And how it gets stimulated is the suckling stimulus. As soon as the baby starts suckling for milk, the prolactin levels rise even further, let down. And that's how the nursing starts. Now, there are a number of causes where prolactin levels are high, and they shouldn't be high. And these are mostly made up of the pituitary growth that I was telling you about, the prolactinoma. But there's a whole host of disorders that we look at. Everything from hypothyroidism, it's a low thyroid state. It can include people with polycystic ovarian syndrome can have a high prolactin. There's no pituitary tumor underlying this, but that can raise the prolactin. And there's a whole host of medications, almost all of the antipsychotic medications that we use. Many of the antidepressants can do this, can raise prolactin. Prozac can raise prolactin. So the example would be that someone's placed on an antipsychotic agent, for example, and they're doing fine, and the woman starts losing periods and starts having nipple discharge, for example. And that's because the medication is causing a rise in prolactin. So we always have to rule out other causes of prolactin elevation. Another one, with the opiate epidemic that we're seeing in this country, with that is coming a rise in prolactin disorders, because opiates themselves, all kinds of opiates, can raise prolactin directly as well. So it's not unusual that a man or a woman who is taking an opiate for chronic pain control can lose some sexual function, and this is one of the main reasons why that happens. So we always look for these secondary causes of this before we settle on the fact that the person probably needs an MRI scan to look for the presence of a pituitary tumor. Now, how do we manage these types of disorders? The fortunate thing for the people who have prolactin disorders, or the prolactin tumors, I should say, is that these are very, very amenable to medical therapy. Most people that have prolactin tumors do not need surgery. Most do not need radiation therapy. They can get away with the medical therapy, and that truly works well for these diseases. There's 2 medical therapies that are available in the United States. There's a number of other ones worldwide, but we've, for various reasons, which we can discuss later, have not allowed them into the United States, mainly because of side effect profiles of them. So there's 2. Bromocriptine has been around now for 40 years, 50 years, and it's a very easy to use tablet that's given 1 to 3 times a day. Cabergoline, some of you in this room may be on this medication, also called Dostonex. This is usually given once or twice a week. Very effective. Cabergoline is a little more effective than bromocriptine in lowering prolactin and better tolerated. I think the biggest side effect profile of these medicines is stomach upset, nausea, and some headaches, but that can usually be mollified by using the right doses, starting off kind of slowly and lower doses at first. There's been some concern that cabergoline can cause a cardiac valve problem. That is not so clear, but we do cardiac echoes in people who are on this medication, particularly if they're on higher doses of it. The literature on this was based upon people who have Parkinson's disease who were receiving very, very, very high doses of cabergoline. And in people who were like that were having some heart valve problems. But the doses that we use for these types of disorders, pituitary tumors, that does not seem to be the case. And literature, in my experience, suggests that there's no connection with heart disease, in case it ever comes up and you read about that. Now, these medicines work well. They work well, and they work fast. So this is an example of the top level of a pituitary tumor. You see on the far top right picture there, it looks like a golf ball sitting in the base of the skull. That's a pituitary tumor. And if you look below, this is just a few weeks out using this medical therapy. It really does shrink these down. Here's a view from the side, shrank it down. You can see it's gone from a golf ball to a nothing ball. It works very well. People's vision, if it's impacted, if this tumor is pushing up on the eye nerves up here, that person's visual fields, their visual function can improve within 24, 48 hours. It's an amazing sight when this happens, that the person says, oh my gosh, I can see again just a day or two after starting this medical therapy. So it shrinks these tumors pretty fast. Very, very effective. Thank you. Oh, thank you so much. Aha. So very effective therapy for these tumors. It works in 80, 90% of people. Most people, this works well, and that's all we need to do for the treatment of prolactin tumors. When do we operate on people who have prolactinomas? I just said that most people have a nice response, and the prolactin comes down, the tumors shrink, everything we want to do happens. We operate on those people, the minority of people, that just the drug just doesn't work. It's lack of response. There are some people who don't tolerate the medical therapy very well, and it's usually due to nausea. In my experience, is what happens, nausea and some dizziness. If that happens, that may be limiting, and we may not be able to use it. And there are those people that the tumor grows despite what we do, and that would be a reason, again, to refer for surgery. And there are tumors, and you may see some of these as the day goes, where they're not solid, where some of the tumor is made up of just some fluid in it called a cyst. And the cyst fluid, there's nothing, it's like a bag, it's like a balloon of water. You can't shrink it. You can drain it, but you can't shrink it with a medicine. And people who have tumors like that really do need to have surgery. But the majority of people, we get away with medical therapy only. I'm going to move on from the prolactin tumors to the growth hormone tumors. These are the people who have a disorder called acromegaly, large body. These are tumors that make too much of this growth hormone. So this is an example of, and you're going to see another example as the day progresses. They're both big people, but this fellow is the one that has the growth hormone disorder. This fellow, my understanding, put his little town of Romania on the map. He grew fast. He is what's called a pituitary giant. This is what happens when the growth hormone is produced excessively before the person stops growing, before the bones fuse, before around 17, 18 when people stop growing. If the growth hormone is high before that time, people get large. He was a phenomenal basketball player. He came out for the trials for the NBA, and when he was trying out for the NBA, no one thought about this beforehand because he was like the superstar athlete. He came for the NBA, and the people noticed this, and he was, didn't I tell you when I asked you? Silence phones, it's always me, so there you go. It's okay. I'll call my son later. Yeah, I know. And then he had therapy, he had surgery, he's had radiation therapy and medical therapy. He's now under control. But this is an example of what happens if it happens early in someone's life in terms of adolescence. So acromegaly, things get larger. That's what happens in this disorder. And there are a number of changes in the body that can occur. And if you know anybody that's had acromegaly or you have acromegaly in this audience, you'll know what I'm talking about. Frontal bossing means the frontal bones grow larger. And that's because the frontal sinus gets thicker and larger. The tongue, the jaw, these all enlarge, and the teeth can space. Everything gets bigger. The hands get larger. And so people, this happens so slowly over so many years that people don't notice it. They think, oh, I just don't look as good, or I'm not sleeping as well. And this is what happens. And in fact, we have data that it can take between 10 and 12 years, if you look back at photographs, before someone thinks about the diagnosis. And it's generally when someone sees a new physician, they say, do you have this problem? Or they see an old uncle they haven't seen in years who says, boy, I haven't seen you, but something's changed. So when this happens, people start thinking about the disease. But the problem with acromegaly is that we diagnose it usually much later than it starts to occur because we just don't think about it, and because the changes are so subtle and so slow in onset. So by the time someone is diagnosed, people are often pretty thick. But it's not just the outer part of the body that's thick. Internal organs can get thick. The heart can get thick and not pump as well, for an example. So we have many concerns about this. This is an example of someone that's been published. And the reason why we have the same background, she's a school teacher. So this is the annual high school yearbook. And here, at the bottom right, which is 11 years after the first photograph, if you can see this picture, there are some pretty classic changes. I mean, there's ridges of her brow are thick. She has very thick lips. It's hard to see from the back, but her jaw is pushed out. And along the path, you can see, now that you know that she has this, you can see some subtle changes, particularly of the lips, particularly of the nose, around the eyes. They could say, oh, I can see these changes, but you know, I've seen hundreds and hundreds of people with acromegaly, and if I saw her here, maybe here I may have missed it. And I'm a specialist on this. Here, no. But this is the problem. It takes many, many years for detection because the changes can be so slow and subtle. Now, people who have this disorder have many complications of this. That includes headaches. It includes joint pains. It includes sweating. Everything gets overblown. But often people, the primary care providers who see them, their internists, having never seen a patient with acromegaly in their careers, or maybe one in medical school many years before, they don't think about this. It's not a common disorder. And therein lies the other rub with this. It's important for someone like me to be educating primary care providers and other specialists to be thinking about this problem. So because of the overgrowth, there are a number of systemic medical complications that occur. Heart disease, particularly because the heart gets thick and doesn't pump as well, that can cause a form of heart failure. Hypertension, diabetes are common. About 40% of people with acromegaly have high glucose levels and diabetes. Sleep apnea syndrome is almost universal in people. So if someone has acromegaly and is snoring, I'm telling you they have sleep apnea syndrome. If they're not snoring, they probably have sleep apnea syndrome. It's very common. And many people describe, I wake up, I don't feel like I've slept well. I don't feel like I went to sleep. I didn't have a quality sleep. That's very classic with this. Cancer can happen with acromegaly. The literature is mostly focused on the colon. So we do colonoscopies on everybody who has acromegaly because colon polyps are very common, and these polyps can be pretty malignant and can become malignant. So we're aggressive at monitoring the colon to rule out cancer. And if someone has cancer and they have acromegaly, we're very aggressive at treating it. There is literature, there's experience that people who have cancer that have this, the cancer can be more aggressive. So we are highly focused on making sure that we normalize the levels in such people. Arthropathy, that means joint disease. This is probably the part of acromegaly that people describe the most, and it's the hardest part of acromegaly, because no matter what we do with acromegaly, once the joints are involved, they stay involved. So if I'm able to take a person, normalize their growth hormone with the help of a surgeon, myself with medical therapy, whatever we do, the numbers are normal now, the joint pains usually linger. And when you ask people years later, what is bothering you now? You've been in remission all these years. What bothers you? It's the joints, the hips, the knees. They often need to be replaced. So this is a problem with diseases. Another reason why we're aggressive at treating. We use a lot of non-steroidal agents to try to help the joint pains if they occur, to try to diminish the inflammation, which may improve the chances long-term of not having to have replacement. And there is a risk of dying early with acromegaly. Given all the medical complications that I described, these can cause premature death. The good news is that we can negate this risk if we bring the growth hormone levels back down to a good level. We have plenty of data on that. I've published on this before, that if we can bring the numbers down to normal, this risk of premature death is gone. How do we test for this disease? Well, the problem is too much growth hormone, but you can't just measure growth hormone because the levels go up and down, and the overlap with normal is pretty significant, and there's no really known cutoffs of what's used for growth. We measure it, but it's not really useful for the diagnosis. We can do what's called a glucose tolerance test. Many of you have had these, where we have people swallow a bunch of sugary glucose, and then we measure growth hormone levels over the next 2 hours, and what you'll see in normals, growth hormone levels go pretty far down. They suppress, that's what glucose does. It makes growth hormone go down. But in people with acromegaly, it doesn't go down. And there are cutoffs we can use to say, oh my, that's not a normal glucose response. Remember, we usually use glucose tests for diabetes. Here we're using it to look at growth hormone. There's a test called IGF-1. Many of you may have heard of this test. It's a marker. It's called insulin-like growth factor 1, IGF-1. It's a kind of a measure that we can use to see how much growth hormone has been present for the preceding weeks. It's a marker. This is what we use. It's what we use for diagnosis now. Any time of day, you send off this one blood test, and if it's high, they have too much growth hormone. If it's low, they probably have too little growth hormone. We're going to be talking about that as the day progresses. So IGF-1 is a test that we do in people who have pituitary tumors and we're concerned about acromegaly. This is the test we do. It's a random test called IGF-1, 3 letters and a number. What can we offer people who have acromegaly? There are 3 types of interventions we have. The main one for acromegaly, the best thing we can do is refer someone to an experienced surgeon. I am very fortunate in my role as endocrinologist at Stanford to have superb, superior surgeons available that I can refer to in my clinic. Not all centers have that, and those that do are blessed because the outcomes of these surgeries are dependent upon the experience of the surgeon. If someone sees a surgeon at a community health hospital that does 1 or 2 of these a year, there's plenty of literature on this now that the outcomes are not as good in terms of normalizing the values and also minimizing the side effects of surgery. So surgery is a terrific approach. For the small tumors, we can remove about 90% of them. For the larger tumors, at least half of them. And then we need to move on to medical therapy at that point. Radiation therapy, which you're going to be hearing more about as the morning progresses, is generally used for people who the surgery has been incomplete and or the medical therapy isn't cutting it. So we usually use that as like a downward option. We don't start with that. Different parts of the world where there's limited, there's socioeconomic barriers that limit availability of medical therapies, or there aren't good surgeons, often reach for this first because it's maybe cheaper compared to medical therapies depending on where we are in the world. Developing countries may try to refer patients just for this, radiation for example. But in developed countries, this is the mainstay of therapy is surgery. The medical therapy I'm going to talk to you about a little bit now. I talked a little bit about the cure rate with surgery, which is somewhere around 90% with the small tumors, the microadenomas, and about half the people who have the larger tumors. Complications are minimal. Mortality is very low with these surgeries. And again, you're going to be hearing more about the surgery and side effects of consequences of surgery in the minutes to come. So what happens if someone goes to surgery with the best surgeons that we can find, that we have available to us, and there's still tumor left, there's still disease left? This is where we consider a reoperation. If there is tumor that's accessible to surgery, with a good surgeon, an experienced surgeon, there probably isn't any more accessible surgery, the tumor may have moved beyond the pales of what's considered safe for surgery, and so we can't do another operation. If we can, we will, but if we can't, then we have to move to the next steps. And that usually involves medical therapy. I'm listing a bunch of medicines. I'm just going to discuss in big picture what these are. I'm not asking you to look in details at each one. Some of these medicines may be familiar to you in the audience. The mainstay of therapy is a class of medication called somatostatin analogs. Somatostatin is a hormone. There was a Nobel Prize for its discovery many, many years ago. It's a hormone that's made almost everywhere in the body, and it has a major, major role here to impact how much growth hormone we make. So the base of the brain makes somatostatin, and it travels down the blood vessels to the pituitary gland and tones down growth hormone. It turns it off. It does this every few minutes in the brain normally. We took advantage of that and took the somatostatin, played around with it a little bit, and made it in such a way that we could use therapeutically, and it lowers growth hormone but keeps it down with the medicines we use. There are 3 that we can use. There's the octreotide and lanreotide, which are, as far as I'm concerned, they're equal. They have 2 drug companies that are competing with each other, but they really are similar medicines, both excellent medications. There's a 3rd medicine called Signifor, pasireotide. It's another somatostatin analog. The problem with it is it causes high glucose diabetes in a lot of people, so I haven't utilized it in a couple of years now because I'm concerned about the side effect profile of it. But these are the 2 that we tend to use. Do you remember the dopamine drugs that I talked about with prolactin tumors, the bromocriptine and cabergoline? We can use those as well. And I'm going to talk a little bit about another one called Somavert, which these 2 classes of drugs go right to the pituitary tumor. They say, stop making growth hormone. That's how they work. This last class of medicine disregards all that. It goes to wherever growth hormone is going to hit in the body and blocks it there. It's a human growth hormone that's been engineered to block normal growth hormone. We were involved in the development of this a number of years ago. Terrific medication. These lower growth hormone, this one blocks growth hormone. You could use them in combination, one to lower, one to block, and some of you may be on that combination now. So the somatostatin drugs, they're effective. They work in about 1/3 of people to normalize growth hormone. They work on almost everybody to lower growth hormone, and they help relieve the headaches, they help relieve the joint pains, they make people feel much better. Normalize the blood tests in about 1/3 of people. The bigger the tumor, the harder it is for the medication to work, so it's more effective with smaller tumors, which is why we like to operate up front anyways to try to lessen the tumor size, because the medical therapies work better the smaller the tumor. And the tumors can shrink with this, usually modestly, not a lot, not like the picture I showed you of the prolactinoma, but they can shrink in size. And that can be effective, at least pulling the tumor out of an area that may be difficult to operate, so now the surgeon can go in and operate, for example. The side effect profile of these medicines, the somatostatin drugs, probably the biggest one is gallstones. We used to do ultrasounds every 2 or 3 months, but we stopped doing those years ago because we found that even if someone has gallstones, a number of us probably have gallstones. I just don't want to know about it. Just don't tell me. If they become active, we'll find out. And it's usually, the usual story is a morning after KFC. It's a greasy meal, and amongst other things, you get abdominal pain. That's the gallbladder attack. But we don't look for it, but they happen pretty frequently with this medication. This medication slows down the gallbladder movement so the stones can form. Other problems can occur. There's a number of other potential side effects, but generally it's managed and handled really well. Many people do get some diarrhea after. It's a 1-month injection to get some diarrhea the first couple of days, and that usually resolves. So it's usually a very well-tolerated group of medications. We talked earlier about the dopamine drugs, bromocriptine and cabergoline. That can be used, and the advantage of these is that they are pill form, they're cheaper, and particularly in developing countries or in countries that have limited access to medical therapies, this is often started first. Because boy, if this works, then that would be a lot easier to utilize, particularly in climates where there's socioeconomic barriers. The last one to talk about in this group is the growth hormone blocker. I talked a little bit about this. And we first started working with this medication in the 90s, and it was found to be so effective. So again, this is a normal growth hormone molecule. It's been engineered to block the body's growth hormone from working. So it blocks. It's a growth hormone blocker. And it doesn't hit the tumor at all. So one of the potential concerns is that the tumors can grow on this medication, but fortunately it's pretty rare that that happens. And it works in more than half of people. It's probably our most effective medication for acromegaly. It works in a lot of people. We use it quite a bit. It's given as an injection. The person has to give themselves in the skin, anywhere from once a day to once or twice a week. So it's a great medication. Part of the problem is cost, and we have our breakout sessions today. We can talk a little bit about that if that's been an issue of obtaining access to these medications, but that's one of the issues with this medical therapy. But effective medication. Now, we're moving on, and again, we're going to be spending time on all these more detail. I just wanted to give you a sense of these issues, and that involves the Cushing's disease. These are tumors where there is too much ACTH. This is the hormone that controls adrenal gland production of cortisol. People get blown up from steroids. And I'm showing you some examples. This is an example of a patient who had, those of you who have Cushing's in the audience have heard about it, may recognize this. This is the same person before and after having Cushing's disease. And what you'll see is that the person's face and neck are blown up with fat, and what generally happens is that there's a redistribution of fat. So the arms and legs get really thin. It's almost like a snowman, where the arms and legs get thin, and the fat is redistributed up in the middle, up into the face and neck and abdomen. Here's an example of the tummy. You can see the skinny arm, big belly, all the fat's been redistributed like this. The skin actually gets really thin, breaks down, people get easy bruising, and that's a very common scenario with Cushing's. Here's an old patient of mine who had this, and you can see the full face. You've got acne, very common with this, and the head and the neck is full with fat as well. What happens here is in normal, the pituitary gland makes this ACTH, which circulates in the body and goes to the adrenal glands and says make cortisol. And that's normally how we make steroids. And we need steroids every day to maintain blood pressure and to maintain our response to stress. Everybody needs a little steroid in the body every day. You don't want too much of it, though. Too much of it, and you can see all these other issues such as easy bruising, high blood pressure, diabetes, similar to what we saw with acromegaly, weakness, weight gain. People can lose hair on their head, gain hair everywhere else. And one of the issues with this is people are relatively immunocompromised. They're at risk for infections. That's always a concern when someone with Cushing's, for example, goes on an airplane ride. And the air in the airplane is filled with stuff we don't want to know about. And that can hit us. And this stuff, there's fungus, there's viruses, you don't want to know. It's there. And so people do with Cushing's, like anybody else who can be immunocompromised, can get infected like this. So Cushing's, how do we diagnose it? We look for high levels of steroids, and there's various ways of doing that. We can look in the urine. We look at how much cortisol is produced in the urine. We can look at it in the blood. We're trying to see if someone has very high levels of cortisol to go along with the clinical findings that we have. So we do urine testing. We do blood testing. The blood testing usually starts with, we have people take a pill of dexamethasone, a steroid, late at night, and then we measure cortisol the next morning. Normally, if I give the steroid that will suppress, I'll make our cortisol levels go down, but not in Cushing's. So there are cutoffs of what the response would be after a dose of steroids at night. We can measure urine cortisol, which we could do. It's cumbersome. Someone's got to bring a bottle with them throughout 24 hours and collect all their urine, but it's an effective way of assessing for Cushing's. Here. So once we do this, once we measure these tests and we say, oh my gosh, this person has high cortisol, they look like they have Cushing's, the next step is to figure out where this is coming from. What's the problem in the body that's causing this? Because there's a number of problems that can cause this. So my role as an endocrinologist, I spend a lot of my time trying to figure out where the source of the problem is. Because wherever the source is, we need to attack that one problem. So let's discuss this. I showed a minute ago that how the pituitary gland works. Pituitary gland makes its ACTH, goes down in the blood to the adrenal glands, which say make cortisol. Okay? And what normally happens is that cortisol goes back to the blood to the brain and turns off the system. So like there's a loop. It turns it off, turns it on, turns it off, turns it on. That's normally what happens every few minutes in our body. Now, this is supposed to be, and the circle here is a growth on the adrenal glands. So one of the causes can be there's a tumor on the adrenal glands producing way too much cortisol. And when that happens, the cortisol levels rise, and the person develops Cushing's syndrome. And so we need to, if the problem is in the adrenal glands, I need to refer this patient to an adrenal surgeon to remove that growth. On the other hand, the person could have a tumor of the pituitary gland. That's called Cushing's disease, making too much ACTH. And if we get a tumor on the pituitary gland, that will make the ACTH rise, cortisol will go up, and the person will get the Cushing's disease. They may also have a tumor elsewhere in the body. It's not uncommon that the tumor is in the lungs, called a carcinoid tumor. So I just told you the tumor can be in the adrenal glands, the tumor can be in the pituitary gland, the tumor can be somewhere else, such as the lung. So my job is to figure out where that problem is coming from. So I spend a lot of my time trying to do this, to investigate the source. So the number of tests that we can do to determine this, we can do MRI scans of the brain. We do blood measurements for ACTH to see if it's, because if the ACTH level is high, that means it's coming from the pituitary or the lung source. If the ACTH is low, that means it's coming from the adrenal source. These are just to give you a sense of the kind of evaluation that we do to determine the source of the Cushing's syndrome. One of the things that we do, and Dr. Dodd is the expert at this at Stanford, is a test where we place, if we're not sure where the problem is coming from, that Dr. Dodd will place catheters up through the body, up around the pituitary gland. It's a catheter procedure where you're measuring ACTH and you're asking the question, is it coming from the head or not? And if it is coming from the head, is it coming from one side or not? Because if the answer is, oh, it's coming from the head, it's coming from the left side of the head, that means that the answer is probably a very, very small tumor in the left part of the pituitary gland that we just don't see on scan. And we'll refer the person to the surgeon to remove. I'm just going to say that when we approach people who have Cushing's, I told you a lot, and I just wanted to make it clear to you that it's very complex how we approach someone, not only to make the diagnosis, but to figure out where the source is coming from, and then to make the appropriate referral to a surgeon to remove wherever the problem is, whether it's in the lung, whether it's the pituitary, whether it's in the adrenal gland. If we operate and there's still disease left over, this is where we do additional therapies. Like the other tumors I talked about, we may have to march down the road of other therapies for these patients. And these are the times we consider radiation therapy. There's medications, the same dopamine drugs I told you about before can be used here as well. There's other medical therapies that we can use, particularly those that block down the adrenal gland. There's medical therapies that do that go to the adrenal gland and block it down. And there's even a medical therapy that blocks cortisol wherever it goes. Remember I told you there's a medical therapy that blocks growth hormone? There was one that blocks cortisol as well. Turns out this one is the same thing as the abortion drug RU486. Not only does it have uterine effects for abortion, but it also blocks cortisol. It's a very effective medication when used on a daily basis to block cortisol wherever it goes in the body and to make the person look and feel much better. That's called mifepristone. The last thing we can do in somebody who has Cushing's that is excessive is we can do surgery. We remove the adrenal glands, and we do that usually in people we've tried other options, nothing else has worked. We'll surgically remove the adrenal glands. It's called adrenalectomy. Or in a young woman who wants to conceive and has active Cushing's. These medical therapies, particularly an abortion drug, you can't use in a woman who wants to conceive. So what we do in that situation is we surgically remove the adrenal glands and replace back the cortisol. That's the most effective way to help a woman become pregnant. Before we move on, some slides are missing, and I just wanted to say there are other types of disorders that we see in the pituitary area. There are non-pituitary tumors. I'm sorry the slide isn't here, but that includes tumors such as meningiomas. There's cystic disorders called craniopharyngiomas or Rathke cysts, a number of other diseases. And there's even a disorder where a tumor can become bloody. It's called apoplexy, where it may bleed and die, and that's a surgical emergency because the person gets very severe headaches. These are all different disorders that we need to manage, and we'll be discussing some more of those as the day progresses. So I'm going to stop here. I've said a lot. Do we have time for questions, you think? Or we have a few minutes for questions, and we're going to be moving on to if you can hold off on questions about surgery or radiation therapy, we're going to be discussing that in a few minutes. Are there any general questions that I can address right now? Remember, we're going to have time for more specifics in the breakout sessions later. Please.
That was it.
There you go. I just wanted to see it.
Oh, sure. So I did skip this. Sorry. I thought I was throwing out too many numbers. I was trying to. Sure. So surgery if we determine, the question here is, what's the outcome of surgery for Cushing's disease? If we determine that the problem is, for the Cushing syndrome, is in the pituitary gland, there's a tumor, the overall international rates are that surgery is curative in about 60% of people, 60 to 70% of people. And we often need to do a second operation to go back and remove a little more of the pituitary gland. These are really hard to see. These are microscopic disorders that the surgeon may or may not see when they go in for surgery. And what we do in that situation is, for those of you who've had Cushing's disease, know what I'm talking about, is we have people in the hospital after surgery. We keep people in for up to 3 days, measuring cortisols to see if the cortisol level comes down. Because we may not have any tissue for a pathologist to look at. We may not have that kind of specimen. And if the cortisol does not come down, we often go back and do a second operation. And when we do that, the numbers go higher, up to about 80% cure with surgery, which means there's about between 20, 30% of people will need some other form of therapy. The other form of therapy is the medical therapies we're talking about versus radiation therapy versus adrenal therapy. That's about the numbers we have for Cushing. Can I answer your question? Sure. There's a microphone.
The microadenoma and the macroadenoma, are those two totally different things? Or if the microadenoma is not detected, does it eventually become a macro?
Yes, that's a good question. So the question was, I distinguish the tumors by size, saying some are micro and some are macro. Remember, the cutoff was 10 millimeters. 1 centimeter is the difference. They are different diseases in that the ones that are micro, the small ones, by definition, are so small they're not going to push on any other structures, such as the eye nerves, to cause visual compression or compromise. It's not going to push on other brain tissue. They're too small for that. So the reason to operate on those really is if they're causing functional, if they're functional, if they're causing acromegaly, they're causing Cushing's syndrome, or is there a high prolactin level? Do we need to use medical therapy to intervene? The macroadenomas, by definition, are larger. They're the ones that have the risk of causing chiasmal compression, of causing visual compromise. And so it's kind of a different disease because now we're worried about the local structure effects. Very worried about that. That's where you do visual field testing. We have people see an ophthalmologist to ensure that there is no compromise of the vision. You asked the question, can micro grow to macro? Everything can grow, right? It's living tissue. Had to come from somewhere and grow somewhere. That said, it's interesting. If you look at large series of people who have the microadenomas and you ask the question, how often do they grow to big ones? It's uncommon. They kind of stop growing. So if someone has a microadenoma and they're not causing any functional problem, they're just sitting there and they're just inert, and it's like, now that we know about it, like I wish we didn't know, because now we have to think about it, and it probably never would have harmed someone in the first place, they tend not to grow. So we generally, if someone's got a small growth, not harming the person, not producing any hormones, then what we do is we monitor them maybe every year with an MRI scan for a few years, then sort of space it out if things stay stable. Because they could have been there for the last 10 years, we just don't know. We don't know what the baseline is. So if it's small to start and not doing anything, we usually leave them in. So we're not worried about their growth. The literature is about 1 out of 5 of them grow to a level that we need to consider doing something, such as surgery. Does that answer your question? Please.
You mentioned some other tumors. Is there any connection? I had a meningioma that had actually invaded the skull and the veins, and then about 8 years later, then I had a macro pituitary tumor that caused the acromegaly. Is there a connection between the type of tumors that are growing and my expectations that anything else could go wrong?
Yeah, so this example, if you don't mind if I summarize that, someone who had a meningioma, that's another kind of growth that comes, it's a tumor that comes out of the meninges. Maybe we could talk a little bit about that. It's in the same area. It can look a lot like a pituitary tumor. It's treated a bit differently, surgery for sure. And you talked about how another tumor occurred in the same area, pituitary tumor making growth hormone. They generally are not connected. It's not connected in terms of there's no genetic disorder that will bring them together. It's very, the vast majority of times you'll have one or the other, not both. So it's unusual to come together. I've seen a couple people that do. And when this happens, the concern is, remember I said earlier that growth hormone can make things grow and we're always worried about someone has acromegaly, the growth hormone that, for example, they can get cancer. If they have cancer, it can be more aggressive. Meningioma is the same thing. The literature on this is kind of sparse, but my own gut feeling has been if someone has both, which is very unusual to have both, if that happens, then the growth hormone can cause meningiomas to grow maybe more than they would have otherwise. So we're very aggressive about managing that acromegaly part, the growth hormone tumor. But I wouldn't expect you to have other kinds of pituitary diseases because it's very unusual for that to happen. There's no clear genetic connection. But we do worry about not only meningioma growth, but other tumors growing with growth hormone, like I said earlier. So we do a lot of surveillance for that. Over here, Erin. This is Erin Whip. I introduced her, but she wasn't in the room at the time. Hi, Erin. Thanks, Erin.
Hi, Dr. Katznelson. I was wondering if you could speak a little bit more about craniopharyngiomas and just some key features.
Are you going to be discussing? We want to talk about it. Do you mind if we? It's a very important topic, craniopharyngiomas. We're going to be discussing a lot more about that in two ways. One is the kind of the surgical approach to craniopharyngiomas, and I'm going to come back and talk more about what's very common with craniopharyngiomas is low pituitary function that happens with this, and all the replacement strategies we'll have to use. I'll be discussing that in a few minutes. Okay. So if you don't mind holding off on that, we'll come back to that. Sure. Over here, Aaron.
Hi, how often do you encounter polysecreting tumors compared to just ones that just secrete one hormone? So
polysecreting tumors, there are a couple ones that tend to happen together. The most common one is growth hormone and prolactin. So the acromegaly with prolactin, and that's because they come from the same stem cell. So it's not uncommon at all. About half of them, almost half of them, produce both. It's also not uncommon that we see tumors that make prolactin and TSH, for example, because they come from similar lines. So it's not uncommon. There are certain hormones that tend to bunch together because of their cell derivation. So that is not uncommon. There are certain connections that are very uncommon to see because they come from such different cell types. But having several hormones together is not uncommon at all. The answer? Okay, I'm going to pass the baton. Is there another question?
Was there one more question?
Oh, there is. This is how Erin gets her exercise.
In terms of when these macroadenomas show up, if a male has low testosterone, like from mid to late 40s, is that like a clue that, because that seems a little young? And are hormones the first thing that goes haywire when you get one of these pituitary gland tumors?
That's a really good question, and it's an important one. You know, there are many people who are treated for various disorders that I would say the full evaluation was not performed. An example of this is a woman who has irregular menstrual cycles, and the physician says just take a birth control pill, without having the evaluation done to say why were those periods irregular. And sometimes the evaluation points to pituitary cause. Same goes for testosterone issues in men. If a male, you're a middle-aged male, which is defined, by the way, of 35 up till something, like 60 or something. Anybody who's 35, by definition, is middle-aged, sorry. And if that happens, when I turned 36 and someone told me that, I was, oh my God, it's over. When that happens, when the testosterone level is low, what happens more often than not is the person is just maybe put on testosterone therapy and the rest of it is ignored, when if the appropriate evaluation had been done to look for the other pituitary hormones, and not too uncommonly, you will see that there was, the cause was not just an aging thing. It wasn't just the testicle not functioning correctly, but is more of a pituitary problem. And I think this should be done in anybody who is younger or middle-aged, well, actually all ages. When the level is low, we should look for causes, because if you find a pituitary cause, which may very well be present, particularly that age group that you described, then we would discover the pituitary disease earlier. All too often I see this happening. All it takes is a little bit of other effort to do the appropriate testing. I'm with you on that one.